Welcome to the Deep Dive. This is the show where we try to cut through all the noise, and really deliver the essential, clinically relevant knowledge, stuff you actually need right when you need it. We know how much information's out there. It's just overwhelming sometimes, especially in medicine. So think of this as, well, your shortcut to being properly informed, hopefully with a few interesting bits along the way. Today, we're embarking on a really crucial deep dive. We're looking at chronic pancreatitis and it's often quite debilitating consequence, exocrine pancreatic insufficiency, EPI for short. Our mission here is, well, it's tailored for you. Whether you're a medical student trying to get the basics of GI physiology down, or maybe you're a resident facing diagnostic choices in a busy clinic, or even a gastroenterology fellow refining your strategies for those, complex cases, we're going to distill the clinically actionable stuff, the knowledge that helps you really grasp these core concepts for practice. And we're drawing heavily from some incredibly clear and insightful YouTube videos on this topic. Because understanding EPI, it's not just theory, is it? It's about real patient care.
Absolutely.
It's so critical for recognizing it, diagnosing it, managing patients effectively. It directly impacts their quality of life.
Hugely.
Prevents severe malnutrition, addresses those really distressing symptoms that just ruin daily life. We're really grateful for the clear, structured information that forms the backbone of this deep dive.
And what's really powerful, I think, is seeing how complex physiology, all the intricate details, can actually be distilled into practical, actionable knowledge.
Yeah.
And that's precisely what medical learners need. It helps bridge that gap from the textbook page to, well, confident bedside practice. It's really about empowering you to make those informed decisions for your patients.
Absolutely. And, to truly understand EPI, what goes wrong, we have to start at the very beginning. Lay down the essential groundwork. So let's begin by understanding the pancreas itself, in its healthy, functional state. First off, let's just nail down the anatomy. Where is this thing? The pancreas isn't just some random gland floating around.
No, its location is very strategic.
Right. It's nestled intimately behind the stomach, perfectly situated within that C-shaped scoop of the duodenum.
Exactly.
And that placement is crucial, isn't it? Because it's right there, right at the start of the small intestine, that it secretes its vital digestive juices, precisely where the most intensive digestion needs to happen.
Indeed, and that location is key to its dual nature. The pancreas isn't just doing one job.
Right.
It's an organ with two very distinct vital compartments, the endocrine part and the exocrine part. They perform very different yet equally essential roles.
Okay, let's touch briefly on the endocrine pancreas first. It's hugely important for overall body homeostasis, but it's not our main focus today.
Sure.
This is where you find the islets of Langerhans, those little clusters of cells. They're responsible for secreting hormones like insulin and glucagon, absolutely essential for glucose homeostasis, managing blood sugar.
Critical.
And they also secrete things like VIP and pancreatic polypeptide.
Oh, yeah.
So, yeah, vital for metabolism.
Yeah.
But let's pivot now to our star player for today's deep dive, the exocrine pancreas.
Right. The exocrine pancreas is truly the digestive powerhouse. It's the real workhorse of our digestive system.
Okay.
This compartment is primarily made up of what we call SNR cells.
SNR cells.
These cells are the main secretory units, the factories, if you like. They're responsible for producing this whole array of enzymes that are vital for breaking down everything we eat: carbohydrates, proteins, fats.
And here's a really crucial distinction, isn't it? It's often overlooked, but it's quite important. Not all these enzymes are secreted in the same state.
That's right.
For instance, amylase, which handles the carbs, and lipase, for the fats they're secreted in their active form, ready to go.
Yep, ready to work immediately. Makes sense for digestion, starting quickly.
But then you have the proteolytic enzymes, the big guns for digesting proteins, things like trypsinogen, chymotrypsinogen, carboxypeptidase, and elastase, which we'll come back to.
All right, the protease here.
These are all secreted as inactive precursors, zymogens they're called.
Exactly. And this isn't just some random detail. It's a critical self-preservation mechanism. Think about it. If these incredibly potent protein-digesting enzymes were active inside the pancreas...
Oh, bad news.
Very bad news. They would literally start digesting the pancreas itself. Autodigestion.
Wow.
So it's the organ's own built-in safety switch. Essential.
So the pancreas is really a master of its own protection, making sure its powerful enzymes don't cause harm until they're exactly where they need to be.
Precisely, in the small intestine.
But how do these inactive zymogens get from the pancreas to the duodenum safely without, accidentally getting switched on too early.
That's where the pancreatic ducts come into play. They're not just simple pipes.
What's the ducts?
The ducts are this sophisticated transport system. They collect and drain the pancreatic juice, which contains both these enzymes, and, crucially, bicarbonate directly into the duodenum.
Bicarbonate. Okay, why is that so important?
The bicarbonate secretion is vital. It's a key safeguard. The ducts actively secrete bicarbonate to create and maintain an alkaline environment.
So like a neutral pH.
Exactly. A neutral pH within the pancreas itself and within its ducts. And this alkaline environment is what prevents that premature activation of the proteolytic enzymes. It stops trypsinogen, for example, from turning into active trypsin too early.
Protecting the gland from itself.
It's an elegant system. It really makes you appreciate the engineering of the human body.
It does.
And it also really begs the question, doesn't it? What happens when this finely tuned system breaks down? When these essential enzymes are missing, or maybe they get activated too soon, it's kind of the Achilles heel. Understanding that delicate balance, self-preservation versus self-destruction, is so key to grasping the pathology of pancreatitis itself, not just the insufficiency that results from it.
That's a really profound point, and it leads us right into the clinical picture, doesn't it? Now that we've set the stage with the healthy pancreas, let's bridge that gap to the clinic. How do these intricate processes, or maybe the failure of these processes, actually show up in our patients? We're talking about those telltale symptoms of malabsorption.
Right.
And to make this really stick, let's use that great analogy. The Big Mac.
Yes, the Big Mac, a classic.
So picture it. You've got the bun that's your carbohydrate.
Yep.
You've got the protein patty. And then, of course, the cheese, maybe some special sauce that's your fat.
Right.
This simple, relatable example gives us a really clear framework for understanding how digestion normally works.
And what goes wrong?
Exactly. What goes wrong when the pancreas isn't pulling its weight, leading to those classic malabsorption symptoms we see?
It's a brilliant way to visualize it. Let's start with the bun, the carbohydrates. What happens when carb digestion goes wrong?
Okay.
Normally, carb digestion kicks off in the mouth, right? Salivary amylase starts breaking down starches into smaller sugars, oligosaccharides, disaccharides.
Right.
Not much happens in the stomach for carbs, but then as the food hits the duodenum and jejunum, pancreatic amylase takes over. It's the main player there. It breaks those oligosaccharides and disaccharides down further into monosaccharides, simple sugars, which can then be absorbed by the intestinal villi.
Okay, simple enough. So what happens when pancreatic amylase is low, like an EPI?
Well, those larger sugars, the oligosaccharides and disaccharides, they don't get fully broken down or absorbed in the small intestine.
So they keep traveling.
They keep traveling downstream all the way to the colon. And what's waiting for them there?
Bacteria, lots of them.
Exactly. A whole ecosystem of bacteria ready for a feast. They ferment these undigested carbs.
Fermentation, that means gas, right?
Lots of gas. This leads directly to those really common, often distressing symptoms. Bloating, excessive flatulence, and often osmotic diarrhea because those undigested sugars pull water into the colon.
Okay.
And if this goes on, if it's severe and prolonged, patients can also lose significant weight. They're just losing energy, calories from those unabsorbed carbs. It's a nasty cycle of discomfort and nutritional loss.
That makes total sense.
Yeah.
Okay, let's move to the protein patty. Protein digestion starts differently, right? In the stomach.
Yes. It begins in the stomach. The hydrochloric acid denatures the protein, kind of unfolds it.
Right.
And then pepsin, the stomach protease, starts breaking those denatured proteins into smaller pieces, polypeptide chains.
Okay, so the stomach starts the job.
It starts the job, but the crucial next step happens once that partially digested protein enters the duodenum. That's where the pancreatic protease comes in.
The ones we talked about earlier. Trypsin, chymotrypsin.
Exactly. Activated trypsin, chymotrypsin, carboxypeptidase, elastase, others. They work together like a demolition crew. They break down those polypeptide chains into much smaller peptides and even individual amino acids.
Which can then be absorbed.
Right, absorbed by the small intestinal villi. This is where most of our dietary protein finally gets processed into a usable form for the body.
So if those pancreatic proteases are low in EPI, the proteins just don't get digested properly. What kind of clinical impact does that have beyond just gut symptoms?
Well, similar to the carbs, you'll definitely see bloating, gas, and diarrhea. That's pretty common across the board with maldigestion.
Okay.
But with protein malabsorption specifically, you can run into more profound issues. Significant weight loss is common, muscle wasting too, because the body lacks those amino acid building blocks for repair and maintenance.
Wow.
And in really severe, long-standing cases, you might even see edema, swelling.
From low protein in the blood.
Exactly, from hypoproteinemia. The body struggles to maintain oncotic pressure without enough circulating protein.
And you mentioned elastase earlier. You said it was special. Why highlight that one?
Ah, yes, elastase. It's quite distinct among the pancreatic proteases. Unlike trypsin or chymotrypsin, which are quite fragile, or labile.
Meaning they break down easily.
Yeah, they get destroyed pretty quickly as they travel further down the gut. Elastase, however, is remarkably stable. It holds up.
And why is that stability so important clinically?
Because it's so stable, elastase can be measured reliably in just a single stool sample.
Ah, convenience.
Big time. This makes fecal elastase an invaluable, non-invasive diagnostic marker. It allows us to get a good read on pancreatic enzyme output without needing tedious collections or, invasive procedures. It's really a game changer for screening these patients.
Okay, great point. Now, for the fat the cheese, the special sauce, this is often where the most prominent symptoms show up in EPI, right?
Often, yes. Fat digestion actually starts a little bit in the stomach. There's an enzyme called gastric lipase. It begins breaking down fats into triglycerides, diglycerides, and free fatty acids.
And you mentioned something interesting earlier, that gastric lipase can actually increase in chronic pancreatitis.
That's right. It can be upregulated. It's almost like the body senses the pancreas is struggling with fat digestion and tries to compensate by boosting the stomach's lipase activity. It's a testament to the body's compensatory mechanisms.
But it's not enough, usually.
Usually not, especially as the disease progresses. The real primary workhorse for fat digestion in the small intestine is pancreatic lipase.
Okay.
This enzyme does the heavy lifting, further breaking down fats into free fatty acids and monoglycerides, which are absorbable forms.
But lipase needs help, doesn't it? What about bile?
Absolutely crucial. Lipase doesn't work in isolation. Bile salts, which come from the liver and gallbladder, are essential. First, they emulsify the fats, break large fat globules into tiny droplets, increases the surface area, and then they help form micelles. These tiny packages are necessary for the final absorption of fats, carrying them to the intestinal lining to be absorbed into the lacteals and capillaries. Without proper emulsification and micelle formation, even if you had enough lipase, absorption would be poor.
So, given all that complex machinery needed for fat digestion, what's the big impact when pancreatic lipase is severely low in EPI? What does that look like for a patient?
Okay, so even with any compensatory boost from gastric lipase, fats are profoundly maldigested. These partially digested fats escape down the gut, they don't get absorbed, and they end up being excreted in the stool. This leads to the absolute hallmark symptom, steatorrhea.
Steatorrhea, the fatty stools.
Exactly. Patients will describe really foul-smelling, bulky, greasy, sticky stools. They often say they're incredibly difficult to flush.
Requiring multiple flushes.
Often, yes. Or they might even report seeing visible oil slicks or, shimmering oil lakes in the toilet bowl. It's a very distinctive and often quite distressing complaint for patients.
That's a vivid image, and one that really helps anchor the clinical picture, doesn't it?
It really does. And beyond the steatorrhea itself, patients will often experience associated bloating, gas, and diarrhea. And here's the really critical part regarding fat. Fat is our most calorie-dense macronutrient.
Right, lots of energy.
Loads of energy. So severe fat malabsorption inevitably leads to significant, often quite dramatic weight loss. This is a major reason why identifying and treating EPI is so crucial. It's not just about comfort, it's about preventing severe malnutrition.
And you mentioned another critical, often later stage consequence earlier, the vitamins.
Yes. A critical long-term consequence that clinicians absolutely need to be aware of is the malabsorption of the fat-soluble vitamins.
A, D, E, and K.
Exactly. Vitamins A, D, E, and K. These vitamins are absorbed right alongside dietary fat. So if fat digestion and absorption are severely impaired over a long period,
Deficiencies develop.
Deficiencies will inevitably develop. And that leads to a whole host of secondary problems, from bone density issues and osteoporosis with vitamin D deficiency, to night blindness with vitamin A, neurological issues with E, or even bleeding problems, coagulopathy with vitamin K deficiency.
This connection, tracing it all the way from the missing enzyme to the patient's actual lived experience, like difficulty flushing the toilet or losing weight, it's really fascinating. Have you seen cases where just picking up on those subtle stool complaints made a huge difference?
Oh, absolutely. That's a fantastic real-world point. I remember a patient, actually, a younger guy. He had some subtle imaging signs of chronic pancreatitis, but his main complaint was just fatigue, persistent fatigue, some vague abdominal discomfort, nothing screaming pancreas.
Okay.
It wasn't until he just casually mentioned, almost as an afterthought, that his stool was just weird. And when we dug into that, he described the classic sticky multiple flushes scenario. That was the real light bulb moment for EPI.
So you tested him?
We measured his fecal elastase. It was significantly low. We started him on PERC, the enzyme replacement. And it wasn't just about his gut symptoms, which did improve. It dramatically transformed his energy levels. His weight started to stabilize. His overall quality of life just shot up.
Wow.
It really highlights how those seemingly minor details, things patients might even be embarrassed to mention, can be absolutely crucial diagnostic clues, especially important for residents on the front lines taking those detailed histories.
Okay, so we've grasped the signs and symptoms. The immediate next question for us as clinicians is, how do we definitively confirm this diagnosis? What are the actual tools in our toolbox to assess pancreatic insufficiency? This is particularly important for you as residents learning to navigate that diagnostic pathway efficiently.
Right. So just to reiterate the core problem, in chronic pancreatitis, you've got damage to the exocrine part, the acinar cells making enzymes, the ducts transporting them, or both. This damage leads to a big drop in the synthesis and secretion of pancreatic enzymes into the duodenum. Less digestion, less absorption. So our diagnostic tools are aimed at capturing both the output of enzymes, how much the factory is producing, and the functional impact is that output actually doing the job of digestion.
Okay, so how do we measure that? What's the first, often most accessible tool we reach for?
That would be the fecal elastase test, or FE1.
You mentioned is stable.
Exactly. We prefer it as a first step because elastase is remarkably stable compared to other pancreatic enzymes. It doesn't break down easily in the gut. This means measuring it in a single, simple stool sample is pretty reliable and convenient for routine clinical use. It's really an excellent initial screening tool.
And for our medical students and residents learning to interpret these tests, what do those fecal elastase numbers actually mean in terms of pancreatic enzyme output?
Good question. So generally, if the fecal elastase level is greater than 200 micrograms per gram of stool, that usually indicates the pancreas is producing enough enzymes. Things are likely okay from an output perspective.
Okay, 200 is good.
But if it's less than 200 micrograms per gram, that strongly suggests reduced pancreatic enzyme output. It's a flag for pancreatic dysfunction.
Less than 200. Think dysfunction.
If it's less than 100 micrograms per gram, that points to a more significant reduction in output.
Okay, getting worse.
And if you see a level less than 50 micrograms per gram of stool, that signals severe enzyme deficiency.
Okay, 50 is severe.
So this test primarily assesses the quantity of enzyme output. It's like measuring the factory's production volume.
Right, but just knowing the production volume isn't the whole story, is it?
No, not at all.
We also need to know if that output is actually sufficient for digestion and absorption in the real world, in the patient's gut.
Precisely.
That brings us to the second pillar, the 72-hour stool fat collection. This one sounds intensive.
It is a bit more involved, definitely. It's often considered the gold standard, though, for assessing actual fat digestion and absorption function.
How does it work?
The patient consumes a standardized diet, typically containing 100 grams of fat per day for several days.
Okay, high-fat diet.
Yes. And then they have to collect all their stool for a full 72 hours.
All of it. Wow.
All of it. It's then sent to the lab to measure precisely how much fat is being excreted. It's tedious, no doubt, but it gives us a very objective measure of how well the digestive process is actually working for fat. From this, we calculate the coefficient of fat absorption, the CFA.
Okay, the CFA. And what do the results of this comprehensive test tell us about a patient's fat digestion and absorption?
Right. The CFA number tells us the percentage of ingested fat that was absorbed. In a healthy person with a well-functioning pancreas, the CFA is normally greater than 93%.
Meaning they absorb almost all the fat they eat.
Exactly. Less than 7% of the ingested fat is lost in the stool.
Okay. And in a patient with EPI?
In EPI. If the CFA is less than 93%, meaning more than 7% of fat is lost in the stool, that indicates some degree of fat maldigestion or malabsorption.
Okay, 7% loss is abnormal.
If the CFA drops below 85%, meaning more than 15% of the ingested fat is lost in the stool, that indicates severe fat maldigestion and absorption problems.
Got it. 15% loss is severe.
So this test directly reflects the efficacy of fat digestion and absorption. It tells us if the factory's output is actually translating into usable product downstream.
Okay, that makes sense. And the third pillar ties back to those critical consequences we discussed, the vitamins. Checking blood levels of fat-soluble vitamins, A, D, E, K. Why are these so relevant diagnostically?
Because their malabsorption is a direct consequence of severe, long-standing fat maldigestion, which happens when you don't have enough lipase.
Right.
So if you see low levels of these vitamins in a patient's blood work, it's a pretty strong indicator of very severe pancreatic insufficiency. These deficiencies typically show up later in the disease course as the body's reserves run out and compensatory mechanisms fail.
So low vitamins suggests it's been going on for a while and it's bad.
Exactly. This test reflects the ultimate impact on nutrient absorption and gives us a window into the patient's overall nutritional status, the systemic consequences of EPI.
Now, here's a really crucial distinction, especially for residents making treatment decisions. The difference between pancreatic dysfunction and pancreatic insufficiency. They sound alike, but clinically they're quite different, aren't they? And they lead down different management paths. Why is grasping that nuance so vital?
Absolutely vital. It's really the difference between just identifying a lab abnormality, like a low elastase, and recognizing a true functional impairment that actually requires intervention.
Okay, so define pancreatic dysfunction for us.
Pancreatic dysfunction is characterized by a low fecal elastase level, let's say less than 200 micrograms per gram, indicating reduced enzyme output from the pancreas. However, critically, there is no overt evidence of steatorrhea.
So the 72-hour fat test would...
Normal or borderline. The coefficient of fat absorption would still be above 93% or maybe just slightly below, but definitely less than 7% fat loss.
So the pancreas is underperforming, but the gut is still coping.
Precisely. The pancreas isn't putting out as many enzymes, but the patient is still able to digest and absorb fat adequately, maybe through compensation mechanisms. You wouldn't necessarily treat just a low lab value if the patient is asymptomatic and absorbing nutrients. Okay.
And then pancreatic insufficiency. How is that different?
Pancreatic insufficiency, on the other hand, is defined by both low fecal elastase and overt clinical steatorrhea.
So the 72-hour fat test is definitely abnormal here.
Yes. Significant fat loss with its CFA less than 93% and often less than 85%, meaning more than 7%, and frequently more than 15% of ingested fat is lost in the stool.
And maybe low vitamins, too.
Often accompanied by low fat-soluble vitamin levels, especially in more severe cases. This signifies that the reduced enzyme output is now functionally impacting digestion and absorption, leading to clear clinical consequences for the patient, the symptoms, the weight loss, the nutritional deficits.
So this distinction is key because it tells us when treatment is actually needed.
Exactly. It guides us to treat the patient's problem, the malabsorption, and its consequences, not just an abnormal test result. It helps avoid unnecessary medication, cost, and potential side effects. It's about precision medicine.
Yeah, the differentiation is way more than just semantics. It's a critical decision point. Knowing if the pancreas is merely dysfunctional versus truly insufficient directly guides treatment decisions, especially for our fellows thinking about when and how to intervene. It helps us tailor the approach.
That's a perfect lead-in, because having these clear diagnostic tools and understanding that distinction allows us to actually stage the severity of EPI. This gives us a really practical clinical roadmap. For our gastroenterology fellows particularly, this is where we get into the nuances of severity, which is absolutely essential for making precise therapeutic decisions.
Right. Staging EPI severity isn't just, an academic exercise. It's a systematic way to quantify how bad the exocrine dysfunction is. And it directly informs when and how aggressively we need to initiate pancreatic enzyme replacement therapy, PRRT. So let's break down these stages.
Okay. We can think about pancreatic function or dysfunction across 4 stages. It provides a really practical framework for clinical assessment and management.
Let's start at the beginning. Stage 1, very mild exocrine pancreatic dysfunction. What does a patient in this stage look like, test-wise and clinically?
Okay, stage 1. Here, you'd typically see a fecal elastase level that's reduced, so maybe less than 200 micrograms per gram. There's some decreased enzyme output. But crucially, the coefficient of fat absorption, CFA, is still completely normal. It's greater than 93%, meaning less than 7% of stool fat is lost.
Okay, so they're still absorbing fat fine.
Exactly. And importantly, their blood levels of fat-soluble vitamins are normal too.
So clinically.
Clinically, despite the reduced enzyme output shown on the elastase test, the patient is still digesting and absorbing fat normally. They might be completely asymptomatic or maybe have very mild, nonspecific digestive symptoms, but nothing clearly indicating malabsorption. The body is compensating remarkably well at this point.
Okay, makes sense. Moving on to stage 2. How does this differ? Is this where things start to slide?
Yeah, in stage 2, the fecal elastase output drops further. Specifically, it typically falls below 100 micrograms per gram, so a more significant dip in enzyme production.
Okay, elastase 100 now. What about fat absorption, the CFA?
The CFA might still be normal, still holding above 93%.
Oh, okay.
Or you might start to see an initial subtle decrease. Perhaps it dips into that borderline range, say between 85% and 93%.
So maybe starting to show some strain.
Possibly. But importantly, the fat-soluble vitamin levels are still normal at this stage.
And symptoms.
Patients in stage 2 may start experiencing more noticeable symptoms, maybe increased bloating, more flatulence, perhaps some changes in stool consistency or frequency. But the definitive malabsorption isn't severe enough yet to impact vitamin levels. This is often where the question of intervention starts to come up, if symptoms are bothersome.
Right, which leads us to stage 3, severe insufficiency. This sounds like where things become pretty clinically obvious.
Absolutely. Stage 3 is where you see clear evidence of significant problems. Fecal elastase is significantly low now, typically below 100 micrograms per gram, and very often even less than 50. A marked enzyme deficiency.
Okay, very low elastase. And the CFA.
The coefficient of fat absorption clearly drops. It falls below 85%, meaning more than 15% of ingested fat is being lost in the stool.
So definite statorrhea by definition.
Exactly. That level of fat loss is diagnostic of overt statorrhea. And in some of these stage 3 patients, you might start to see their fat-soluble vitamin levels becoming low normal or borderline. The nutritional impact is beginning to show.
And clinically?
Clinically, there's overt evidence of fat malabsorption. Prominent statorrhea is usually the main complaint, along with associated symptoms like significant weight changes, maybe some muscle weakness starting.
And finally, the most extreme end of the spectrum, stage 4, extreme insufficiency.
Right. At stage 4, everything is low. Fecal elastase is very low, indicating an extreme deficit in pancreatic enzyme output. The coefficient of fat absorption is also very low, well below 85%, confirming significant fat loss. 15%.
And the vitamins.
And most critically, the fat-soluble vitamins A, D, E, and K are definitely low in the blood. Deficiencies are evident.
So this isn't subtle anymore.
Not at all. This isn't just a lab finding. It's a profound clinical state. Clinically, you're seeing severe malabsorption with clear nutritional deficiencies, significant weight loss, maybe muscle wasting, bone pain, and very severe, often intractable gut symptoms. These patients are often quite ill and need immediate, aggressive intervention.
Wow. This staging framework really clarifies the spectrum. And as you said, it directly informs our therapeutic strategy. It allows for that targeted intervention, not just throwing enzymes at everyone with a low elastase.
Precisely. It connects the dots from diagnosis to tailored treatment.
Which brings us neatly to the practical application, actually treating exocrine pancreatic insufficiency. Let's focus now on those therapeutic strategies. And for our gastroenterology fellows listening, this is a deep dive into the real practicalities of using pancreatic enzyme replacement therapy, PERT, and the crucial adjunctive measures too.
Right. PERT is undoubtedly the cornerstone of treatment for clinically significant EPI.
So the absolute key question for clinicians is when? When do we initiate PERT based on the staging and the symptoms we just laid out?
Okay, let's break down the indications for PERT stage by stage. It's quite logical. First, importantly, there is no role for PERT in stage 1.
Even if the elastase is low?
Even if fecal elastase is low, say between 100 and 200, if fat absorption is normal, CFA 93%, and the fat-soluble vitamins are normal, the patient is compensating well. Giving enzymes here won't provide any additional benefit for fat absorption because significant malabsorption isn't happening. It wouldn't improve symptoms related to malabsorption either.
Okay, clear enough for stage 1. What about stage 2? That seemed like more of a gray area.
It can be. In stage 2, if fecal elastase is low, specifically less than 100, and the CFA is borderline, say, between 85–93%. And critically, the patient has significant symptoms.
Like the bloating, the sticky stools, the diarrhea.
Exactly. Discomfort, persistent bloating, sticky or foul-smelling stools, chronic diarrhea. If those symptoms are present alongside the borderline objective evidence, then a trial of PERT is reasonable.
A trial.
The goal here is specifically to see if their symptoms improve with enzymes. If they have a positive response, then you'd consider continuing it long term. It's really about symptom relief when there's objective, albeit borderline, evidence of malabsorption starting.
Okay. And for stages 3 and 4, is it more definitive then? When do we absolutely pull the trigger on PERT?
Yes, much more clear-cut. In stages 3 and 4, meaning if the coefficient of fat absorption is definitively low, less than 85%, indicating 15% stool fat loss, or if low fat-soluble vitamin levels are present, then PERT is definitively indicated.
No question about it.
No question. It's needed long-term. At these stages, the pancreas is clearly unable to produce enough enzymes for adequate digestion. Intervention is essential to prevent severe complications, manage malnutrition, and alleviate those often quite distressing symptoms. These patients need enzymes.
Okay, so we know when to start. But beyond when, how to actually administer PERT is absolutely critical for success, isn't it?
Crucial.
This is a practical pearl for any clinician counseling patients.
Yeah.
Because if patients don't take it correctly, it just won't work optimally. What's the single most important instruction?
The timing. The timing is absolutely everything. Patients must be counseled to take the enzyme pills with their meals.
Not before, not after.
Specifically, in the middle of the meal is often best.
Yeah.
The enzymes need to be delivered to the duodenum simultaneously with the food for optimal mixing and digestion. If they take it too early, the enzymes might pass through before the food arrives. Too late, the food might pass through before the enzymes are fully released and active.
So they have to arrive together.
They have to arrive together. Imagine the food on the plate, the pills on the side, they go down together. Take a few bites, take a pill, eat some more. Maybe take another pill if it's a large dose. That synchronous delivery is key. It's probably the most common reason for treatment failure if patients aren't counseled properly on this.
That's a great practical tip. What about the dose? Is it one size fits all?
No, not really. Dosage is based on the lipase units contained in the capsules, as different formulations have different strengths.
Okay.
Typically for snacks, we might recommend starting around 20,000 to 25,000 units of lipase. For full meals, it's generally higher, maybe 40,000 to 50,000 units of lipase per meal.
And you adjust based on response.
Exactly. You titrate based on symptom response improvement in stool consistency, frequency, bloating, and weight stabilization.
And what about diet? Does dietary counseling play a role alongside the medication?
Yes, it can be very helpful. Advising patients to eat small, frequent meals throughout the day rather than 3 large ones often works better.
Why is that?
It allows for better mixing of the enzymes with the smaller food bolus. It can significantly improve overall digestion and absorption when taking PERT. It's often just easier for a compromised digestive system to handle smaller, more frequent inputs of food and enzymes.
So when we start patients on PERT, what are the ultimate realistic goals? What should we be telling them to expect?
Good question. Managing expectations is important. The primary goals are, 1, control the symptoms of fat malabsorption. That means reducing the steatorrhea, the bloating, the gas, the diarrhea. Get them comfortable.
Okay.
2, improve their overall nutrition, prevent further weight loss, maybe help them regain some weight, and correct any existing nutritional deficiencies.
Makes sense.
But it's also important to set realistic expectations. While symptoms should significantly improve with adequate dosing and timing,
You might not eliminate it completely.
you will likely not be able to completely eliminate all steatorrhea, especially in severe cases. But the aim is always significant symptomatic control and definite nutritional improvement. It's about getting them back to a functional, comfortable life, even if digestion isn't 100% perfect.
Right. This really is where the theory meets practice, turning all that diagnostic workup into a clear, actionable plan for managing patients with EPI.
Right.
But what if symptoms persist despite seemingly adequate P out? Are there adjunctive therapies or long-term monitoring strategies we need to keep in mind?
Yes, absolutely. It's not always straightforward. First, if blood levels of fat-soluble vitamins were low or become low, direct supplementation for vitamins A, D, E, and K is crucial. You have to replace what's not being absorbed.
Okay, makes sense. What else?
Second, consider adding acid-reducing medications, things like proton pump inhibitors, PPIs.
PPIs. If the problem is lack of enzymes, why reduce acid?
Good question. The rationale is that excess stomach acid can actually destroy the pancreatic enzymes, especially lipase, before they even reach the duodenum where they need to work.
So the acid inactivates the replacement enzymes.
It can, particularly if the patient has underlying issues with acid hypersecretion or if the enzyme capsules don't have a robust enough enteric coating. PPIs reduce stomach acid, creating a more favorable pH environment in the upper gut, thereby improving the delivery and efficacy of the PERT enzymes in the small intestine. It's worth trying if PERT alone isn't fully effective.
Okay, PPIs is a potential add-on. Anything else if symptoms are still refractory?
Third, if symptoms still persist despite good PERT adherence, correct timing, adequate dosing, and maybe even adding a PPI, you should consider testing for small intestinal bacterial overgrowth, or SIBO.
SIBO. How do you test for that?
Often with a glucose or lactulose hydrogen breath test, SIBO can absolutely mimic or significantly exacerbate malabsorption symptoms. And it's actually quite common as a comorbidity in patients with chronic pancreatitis due to altered gut motility and anatomy. So it's definitely something to think about in non-responders.
That's really helpful. And what about long-term monitoring for these patients? It's not just about checking symptoms, right?
No, meticulous long-term monitoring is essential. You need to regularly assess the patient's weight and muscle strength, looking for any continued signs of catabolism or nutritional deficit.
Okay.
Critically, you need to evaluate their bone strength. For instance, recommending a DXA scan periodically to check for osteoporosis risk.
Why specifically bone strength?
Because chronic fat malabsorption severely affects vitamin D and calcium absorption. Over time, this can lead to significant bone demineralization and increased fracture risk. It's a major long-term complication.
Got it.
And of course, you should periodically recheck blood levels of those fat-soluble vitamins, A, D, E, K, maybe vitamin B12 as well, and other minerals like zinc or magnesium that can be impacted by chronic malabsorption. It requires a comprehensive, ongoing approach to optimize outcomes and really make a profound difference in their lives long-term.
That comprehensive view is so important. And it brings us beautifully to the clinical integration piece, putting it all together in terms of the thought process in practice. This section is really invaluable for all medical learners, but especially for fellows, because it synthesizes all the diagnostic and therapeutic concepts we've talked about into a practical step-by-step clinical algorithm. It reflects how a clinician might actually think through a case in the real world.
Exactly. This algorithm provides a clear, efficient workflow for approaching a patient where you suspect EPI, particularly if they already have a known diagnosis of chronic pancreatitis. It's about making smart, efficient diagnostic choices to get to the right management plan.
Okay, so let's walk through it. Imagine a patient comes into your clinic. They have known chronic pancreatitis. Maybe their CT scan shows the classic changes we mentioned: gland atrophy, calcifications, ductal issues, stones. What's the very first step in this algorithm to assess them for EPI?
The first and generally the easiest step is that initial screening test, the fecal elastase.
Back to elastase.
Yep. It's the simplest, least tedious sample for the patient to provide, and it gives you that quick, rough idea of pancreatic enzyme output. It's your logical first-line screen because of its ease and reliability.
Okay, so you order the fecal elastase, you get the result back. What's the next immediate step you take for a rapid severity assessment before maybe diving into more complex or tedious tests?
The next crucial step is to check their blood fat-soluble vitamin levels, A, D, E, K.
Why check those next?
Because combining the elastase result with the vitamin levels helps you quickly triage the patient. It often determines how urgent and definitive your next steps need to be. There are two main scenarios here. Scenario A. If both the fecal elastase is low, let's say less than 100 micrograms per gram, and the fat-soluble vitamin levels in the blood are also low.
So low elastase, A and D, low vitamins.
Exactly. This combination immediately suggests severe disease. It points strongly towards stage 4 EPI. This is a pretty clear-cut case.
So the action is?
The action is straightforward. You can confidently start the patient on definitive, long-term pancreatic enzyme replacement therapy, PERT, right away, without necessarily needing further diagnostic delay like the 72-hour stool collection. These patients are often quite symptomatic and clearly nutritionally compromised, so prompt intervention is warranted. Scenario B. If the fecal elastase is low, again, say 100, but the fat-soluble vitamin levels are normal.
Okay, low elastase, but normal vitamins.
Right. This tells you the EPI, while present, based on the low elastase, is not yet extreme. It's likely stage 1 or 2, perhaps early stage 3. They haven't yet developed those systemic nutritional deficiencies reflected in the vitamin levels.
So the action here is different.
Yes. This indicates that further evaluation is likely needed before deciding definitively on PERT initiation. They might still be compensating reasonably well or have milder symptoms. You need more information.
Okay, so if the fat-soluble vitamins are normal, meaning it's not yet extreme insufficiency, what's that necessary third step in the algorithm? The one that gives a deeper objective assessment of malabsorption, especially fat malabsorption.
That's when the 72-hour stool fat collection becomes crucial.
The tedious one.
The tedious one, yes. But it becomes necessary here because it objectively measures the actual impact on fat absorption. It's often the key test needed to truly differentiate that stage 12 dysfunction, where PERT might not be needed, from early stage 3 insufficiency, where it likely is.
And the decision on PERT then hinges on the result of that 72-hour fat test, the CFA.
Exactly. You look at the coefficient of fat absorption result. If the CFA is unequivocally low, meaning less than 85%, indicating greater than 15% fat lost in the stool, this confirms significant fat malabsorption.
So the action is?
Start PERT. This patient will definitively benefit from long-term enzyme replacement. Their symptoms, if present, are clearly linked to measurable malabsorption. However, if the CFA comes back in that borderline range, say between 85% and 93% fat absorption, meaning 7–15% fat loss, and the patient has those typical symptoms we discussed, discomfort, bloating, sticky stools, foul smell, diarrhea.
So borderline test plus symptoms.
Right. In that specific situation, a trial of PERT is warranted.
Okay, try and see.
Exactly. You counsel the patient, let's give the enzymes a try for a few weeks and see if your symptoms respond. If they do get significant symptomatic improvement, then you'd strongly consider continuing PERT long-term. This is where clinical judgment and patient-reported outcomes really weigh heavily in the decision.
That algorithm is incredibly helpful. What's really powerful about it is how it simplifies these potentially complex patient presentations into a practical, logical, stepwise approach. It really takes a lot of the guesswork out of managing these patients, making it so much easier to apply confidently in a busy clinic setting. It helps clinicians efficiently identify who needs what level of investigation, and ultimately who needs treatment, ensuring appropriate and timely intervention while avoiding unnecessary tests or therapies for others.
And thinking beyond just this initial diagnosis and starting treatment, what are the ongoing considerations? What potential future challenges should always be top of mind for clinicians taking a truly holistic, long-term approach to patients living with chronic pancreatitis and EPI? It's not just about prescribing medication, right? It's often about a lifelong partnership in managing a chronic condition.
Absolutely. We've truly covered a vast amount of ground today. Our mission, remember, was to give you a clear, structured, and clinically relevant shortcut to help you feel well-informed about exocrine pancreatic insufficiency in the context of chronic pancreatitis, drawing directly from expert insights.
We really have navigated from the fundamental building blocks, the anatomy and physiology of the pancreas, all the way through the specific mechanisms of digestion, the precise tools for diagnosis, the nuances of staging severity, and then the practical application of tailored therapy.
Yeah.
This isn't just abstract information. Hopefully, it serves as a kind of blueprint for more confident clinical practice, whether you're a medical student, a resident, or a GI fellow.
And as you integrate this knowledge into your own practice, here's maybe a final provocative thought to mull over. What are the potential long-term implications of that subclinical malabsorption, maybe in those stage 1 or early stage 2 patients who aren't overtly symptomatic yet? And looking forward, how might more personalized approaches, maybe different ways of dosing enzymes, or even novel enzyme delivery systems further optimize outcomes, especially for those patients who don't seem to respond fully to our standard therapies now? The field is always evolving, isn't it?
It certainly is. Constant refinement. We definitely encourage you to revisit the source material, the full video series on this topic, for even greater depth if this has piqued your interest. And always consider how these fundamental principles of digestion and malabsorption apply across the other gastrointestinal conditions you'll inevitably encounter in your training and practice.
Thank you so much for joining us on this deep dive. We truly hope this has empowered you with knowledge that you can use to make a real difference in your patients' lives.